Okay, so welcome everybody to Monday evening for what is undoubtedly probably our most popular requested webinar of our series through the summer and into the autumn on peripheral neuropathy. Not something I personally suffer with yet, but I'm very interested. But I know many of us do, and I know that this webinar is going to be very interesting for us. I've taken some questions from you over the past few weeks, which I've submitted to our guests, and hopefully most of those questions will be answered during their talk. However, at the end, I will see if there are any further questions, and we'll see if we've got time to take them. So without further ado, I'd like to introduce Professor Michael Lunn, a neurologist from Queen's in London, and you'll also be familiar with our other guest, Dr. Shirley from UCLH. Probably most of you are patients, it seems to me, but it's great to have both these guys with us tonight to talk about the subject. I'm going to shut up and hand over to you, Shirley.
Great, thank you very much, Bob, and good evening, everyone, and welcome to this webinar. It's great to see you all here. Nerves they have quite an important, prominent role in Waldenström, so it seems. And I'm really glad that my colleague, Mike Lunn, who's based at one of the hospitals within our trust called Queen Square, the National Hospital for Neurology and Neurosurgery, was able to join this evening. We do a joint clinic pretty much every week now at Queen Square to manage people with paraproteins and neuropathies, because it is common. It has a lot of a clinical impact on patients, and we've had this clinic running for, I don't know, 10 or 15 years now, and it's just grown from strength to strength, because actually working together in one room and seeing patients together means that you can kind of feed off each other's ideas and thinking. We come from different angles, but they're complementary, and at the end of the day, it's one patient, even if there are many problems. So we need to try and draw everything together and not work in separate rooms or buildings and do different things, because that also takes a long time. And many people with neuropathy, have either something that's slightly bothersome and a nuisance, but at the other end of the extreme, some people can be quite affected by the neuropathy and be disabled or in severe pain or discomfort. And therefore, it is something that we do need to take seriously. It's not something that we can solve in every case. Even the cause is sometimes unclear after significant investigations, but there is usually something that we can suggest. At least we can guide people as to how to perhaps deal with their problem. So Mike, I'll bring you in at this time. I mean, you are a specialist in peripheral nerve disease. You have shown in your previous lectures a picture of a man or a figure who's got literally thousands of nerves all over the place and coming from the brain and then the spinal cord. And I think what I've learned from you is that neurology is a very anatomically true condition. If something's affected in a certain way, you're likely to get symptoms in a certain way, with exceptions. And I find that you're a detective, really. You're a clinical detective. You see people, you take a detailed history, then you examine them, and then use backup tests to work out what's happening.
Yeah, that's right. Thanks, Shirley, for introducing me, and thank you all for coming this evening. It's a pleasure to talk to lots of people. It's like doing a really big clinic. It's quite nice. As Shirley says, we've been working together for years now. For the reasons that Shirley's indicated, it's much easier working with somebody in the same room with the patient in front of us, and it saves on lots of letters and reduces time and reduces burden for people coming to see us as well. I was to say I'm a consultant neurologist at the National, but my interest in peripheral nerves began a long time ago, 25 years ago now, when I started working with Richard Hughes at Guy's Hospital, and he said there's this interesting group of people with paraproteins and in their blood, and an interesting activity of those paraproteins against something in the nerve. We don't know very much about it. Why don't you come and do a PhD and try and sort out the problem. And that was the sort of beginning of it. And even then, things were at quite an early stage. And in the last 25 years, quite a lot of my life has been around trying to work out what it is about the hematology and the immune systems that damages nerves, how nerves are damaged generally, even when they're not affected by that sort of thing, and basically how to try and make people a bit better. So let's just talk first of all, perhaps about neuropathy, because that's a big topic. So what does neuropathy mean? So lots of people bandy this, use the term. I use it very specifically and others use it less specifically. So neuropathy is damage to what we call peripheral nerves. So they're the nerves outside the spinal cord that run from the spinal cord up here in the neck or in the back, and then they extend out into the limbs. And those nerves can be motor, they can power the muscles, or they come back the other way and they're sensory, and they move information from your skin about what you're touching or what it's feeling back into the spinal cord and then up to the brain. And so there's a loop of information that comes in down those sensory nerves, and then your body acts on that and makes an outward response down the motor nerves. That loop, actually, when it goes wrong, causes tremor when information is, or is one of the causes of tremor, when the information going around that loop is a bit too slow. And that's part of the feature of one of the neuropathies of Waldenstrom's, which we might come back to. As human beings, because we're not, if we were all worms, which we are to an extent, really, we're just worms with appendages. If you annoy a worm or you annoy a snail, it does the same thing every time you poke it. It just retracts and runs away. Whereas we've got brains, and so we interfere with that loop of information that goes from the skin into the spinal cord and back out again, and we can make decisions what to do on a more sort of conscious level. And so how neuropathy affects people is they have abnormal incoming information, so they feel numb, or they have tingles or pins and needles, or sometimes burning or other sorts of pain. And they might be weak as well, because the outward loop might be affected, so they might not be able to control their muscles completely. And that's one of the basic principles of a peripheral neuropathy. That's what a peripheral neuropathy is. It's damage to that loop of information in and information out down your limbs. So what causes neuropathy? Well, I'm not actually, can't show you my shelves over there. I have a textbook over there of the causes of peripheral neuropathy that's 2 volumes big. It's about 2,500 pages long, and it's got about 2,000 causes of neuropathy in it. So neuropathy can be caused by lots and lots and lots of things. The commonest cause of neuropathy in the world is probably leprosy, but we don't have much leprosy in London or in England. We have about 10 cases a year in the whole of the UK. So that doesn't occur very much. And probably the next most common cause is diabetes. So people who have too much sugar in their blood, nerves don't like too much sugar. And that damages those nerves as well, usually in a very characteristic way, affecting the sensory nerves more than the motor nerves. And then there are a number of other common causes. So alcohol, too much alcohol, usually a bottle of wine a day type alcohol or more, can cause neuropathy, often when people don't eat very well. And drugs, some particular drugs, particularly chemotherapies, can cause damage to nerves, but there's a list of about 50 or 60 different drugs that can cause damage to nerves. They're not very commonly used drugs, so they're not the sort of drugs that many of you will be on, although actually as statins, which many of you might be on, are said to cause neuropathy, but I don't believe they do cause neuropathy, because otherwise I'd see thousands of patients with that, which we don't. So there are some drugs that cause neuropathy. So getting on to the specifics of then Waldenstrom's particularly, Waldenstrom's does cause neuropathy, and it causes neuropathies and damage to nerves in a number of different ways. To many clinicians, a neuropathy is just a neuropathy. They can see somebody who's numb or tingling, and they might be weak, that's just the way that they present to people, to clinicians who don't know what the differences between the many neuropathies are. But for me, even the different neuropathies of Waldenstrom's all look rather different in terms of what you say to me and how you look when I examine you. I'll just digress a little bit and say, before we get onto Waldenstrom's specifically in relation to nerves, Waldenstrom's is probably one of the more uncommon causes of neuropathy, although over the last 20 years or so, I think it's more recognized and is probably more common than it was thought originally. So I did a recent search of the literature, the world medical literature, for papers relating to Waldenstrom's and neuropathy. And between 1956 and the year 2000, there were 100 papers, exactly 100 papers, clinical scientific papers on Waldenstrom's and neuropathy. That's it, which is not very many papers in 45 years. Given that by April in 2020, there were already 16,000 peer-reviewed papers on COVID, and that was in 3 months. So for 100 papers in 45 years isn't very many. And then since the year 2000, there have been another 250 papers written in 20 years. So I think people recognize it as an entity and are thankfully a little bit more interested in it and the problems that it causes. But there are many, many other causes of peripheral neuropathy, or numbness and tingling or walking difficulty. And therefore, the patients that Shirley and I get referred to in the clinic, that come to see us in our clinic, the first thing I have to do, is to identify whether the problem is a neuropathy or not. You might come through the door and say, my feet are numb and I've got difficulty walking, or any of the above, or lots of other things. And so part of what a neurologist has to do is say, okay, well, where's the problem coming from in the brain? The brain is the nervous system is a big place. It starts up here, consciousness and mind and thought, and it ends up down in your toes, in your skin. And so I have to try and decide where the problem's from. And it is not uncommon that I would think half the people who come to our clinic don't have a problem with neuropathy at all, even though they've been told it's a neuropathy. They might have a problem with wear and tear in their spinal cord, for instance, or they might have wear and tear change in their brain from high blood pressure or miniature strokes or other things. So first of all, we have to say, is this a neuropathy? That's a clinical a clinical decision on the basis of what you tell me, and then actually what a neurologist can find when we examine you on the couch, because if different bits of your nervous system are affected in different ways, then the examination looks different. You probably will all recognize somebody with typical Parkinson's disease because they have a tremor. And for me, those people look a bit stiff and they have a particular walk and etc. They're easy decisions to make. But somebody who has a problem with their spinal cord will have stiff legs, and when I hit them with my tendon hammer, the reflexes will be very brisk, and I scratch the bottoms of their feet and their toes go up, etc. Instead of down, which is where they're supposed to go. That implies to me perhaps that the problem's in the spinal cord. Whereas when I examine you on the couch and I find a peripheral neuropathy, I might find some muscle wasting. I might find some weakness, usually in the outside bits of your limbs, in legs and feet and ankles or hands. I'll find that the reflexes are all depressed, or they might be partly depressed. And then I can find some sensory loss in a particular distribution with a tuning fork which vibrates, or a pin which is a stimulus of pain, although it's not that painful in the clinic, because all the different nerve fibers transmit
He's got so
different
much
things.
in his brain, he can't cope.
Yeah, sorry, I've got lots in my brain. I can't quite cope with it all.
Somebody's on. Can you put, I think it's Andrew North. Can you put yourself on mute, Andrew?
Oh, sorry.
So I do have lots in my brain. It sometimes gets me into trouble. Anyway, coming to neuropathy. So we decide in clinic that you've got a neuropathy from those clinical features that we find by examining you, and then we have to decide whether the neuropathy is related to your Waldenstrom's or not. And that we do again through a bit of clinical examination. So let's talk about the neuropathies of Waldenstrom's. So the commonest neuropathy that occurs with Waldenstrom's, well, this is, maybe I'll dip into Shirley's region a bit. So you will all know that you have a paraprotein in your blood. A paraprotein is too much of one antibody. Nearly always that antibody, of which there's too much, is an IgM antibody. So Waldenstrom's macroglobulinemia is too much of one sort of IgM antibody. You probably know that antibodies are things in your blood that normally go searching out infections or other things that need removing. And so they have a target, like a key has a target, which is the lock. An antibody has a target that is a bug, for instance. And in Waldenstrom's, interestingly, the target of these IgM paraproteins, IgM antibodies, is a bit of the nerves on the myelin or the insulating sheath. And so the lock for the IgM key, as it were, is something called MAG, or myelin-associated glycoprotein. And so you will have heard of anti-MAG neuropathy, probably some of you, and that is because the IgM antibody targets this thing on the nerve and damages it by binding onto it. And when antibodies bind onto things, they largely damage them. And by damaging the nerve, it damages the insulating sheath of the nerve. And just like if you damaged the electrical insulation on a wire and it short-circuited, if you damage the electrical insulation on a nerve, then it short circuits and it doesn't work properly anymore. My apologies, I'm being attacked by my dog, so apologies. These antibodies attack the nerve, result in short circuiting from damage to the insulating sheath to the nerve, and that gives patients the symptoms they have, which we can then detect. So the commonest symptoms that you get with an anti-MAG neuropathy, patients are often older, usually in late 60s, 70s or older. Interestingly, they're more often men than women, slightly, but women can have this too. Usually the earliest complaint of a typical anti-MAG neuropathy is people are a bit unbalanced. They don't feel so steady on their feet. And when one watches them walk, people walk along not quite like they're drunk, but their feet don't quite go in the right place. They're always slightly sort of off just to one side a bit. Then what used to be said was that there's a tremor, a shake. And the tremor is a funny tremor that's a bit unique in neurology, because not only do the fingers go up and down, but they often go side to side. And the tremor is a little bit jerky. And when I see one of those tremors, it looks like a tremor. It doesn't look like Parkinson's disease, and it doesn't look like other causes of tremor. It just looks like a tremor of anti-MAG neuropathy. It's a very typical sort of tremor. And then patients complain of sensory loss, often numbness in their feet to start with, and not very often they get numbness in their hands, actually, until sort of later on. And people often complain that their feet are bound up by, like they've been bound up in cling film, or a sort of thick wodge of paper or something, so that they feel sort of tightly bound in. And very occasionally it's a bit painful. So some people have complained to me they feel like they've got hot steel boots on. But most often it's not a painful problem. It's more an unpleasant. I can imagine what one's feet feel like if they're bound up in cling film. It's not a very nice feeling, but it's not typically painful. And that feeling rises up, starts at the toes, and sometimes rises up to the knees, and sometimes a little bit above that, but in general it doesn't get any further. And then later on in disease, sometimes people get a bit of weakness at their ankles, which makes their unsteadiness a little bit worse. And so, but that usually occurs late on and is a little bit atypical for what we expect in a Waldenstrom's neuropathy. So that's what one typically complains of. My examination will find the typical features. So you may be a little bit weak, but usually not. It's usually this imbalance, so maybe a tremor. And actually using my tuning fork and pin and other things, usually the tuning fork, interestingly, you can find an abnormality often right up onto the chest from the toes. You can't feel it a long way up, whereas a pin you can feel in the sort of back parts of your feet, or just it goes up to the top of where your short socks would be. So it's a very typical picture of how the sensation is affected. And then usually what one does if you've got a neuropathy is I send you off to a neurophysiologist. So that's a doctor who looks at how the nerves work electrically. And that doctor will use some little electrical stimuli. I'm going to turn a light on actually because it's getting a bit dark. The doctor will use some little electrical stimuli onto a nerve in a limb, and it makes the thumb or the fingers twitch a bit, and then they do the same thing in reverse, stimulating on the fingers and recording back further up the fingers to work out what's going on in the sensory nerves. And they can do that in the arms and the legs, and that electrical picture is very typical as well. And then lastly, you might have some blood tests. Usually I know that you've got Waldenstrom's macroglobulinemia beforehand, so I know that you've got a paraprotein, but we can detect those antibodies that bind to myelin-associated glycoprotein in tests in the laboratory. And so once we've got a typical clinical picture, what you complain of and what I can find on the couch, and we've got the electrical abnormalities that we expect, and an anti-MAG antibody in the blood, then we can say this is probably an anti-MAG paraproteinemic Waldenstrom's-like neuropathy. So that's a sort of process that one goes through to get to what perhaps is the commonest answer within the group of patients that you are.
So Mike,
yeah, sorry, yeah, do interrupt any time because I'll just talk forever.
No, I'll recap. So there was a question about is peripheral neuropathy an umbrella term for more specific neuropathies and conditions, such as radial neuropathy, foot, finger, wrist drops, etc. And I think you've kind of touched on that quite very well and broadly, because you've explained what your view of peripheral neuropathy is. So I think the presentations are very variable, but and that so that it can look different in different people. And
so I'll just answer that one, Shirley, just because that is interesting. So yes, peripheral neuropathy is any damage to any peripheral nerve for any cause. So that comes in that big group of a couple of thousand of causes. And the mononeuropathies, that is damage to one nerve. So somebody's mentioned radial neuropathy there. Your radial nerve is in your arm, and it's what allows you to pick up a pint of beer, actually. That's your beer nerve, because in order to pick up a pint of beer, in fact, I haven't got a pint of beer here, it's a cup of tea. But in order to pick up a cup of tea, I have to be able, I'm not sure I could do it. You have to be able to extend your wrist like this in order to pick up the cup of tea. Because if you've ever tried picking anything up like this with your wrist flexed, you can't do it. It's not a very strong position. And it also keeps your fingers up. And that's the reason that's also relevant to beer is if you've drunk too much and you go to sleep with your arm over the back of a chair and lie there for 2 hours, you'll find that when you wake up, you can't lift your finger or your arm up. Everything's dead like that. So those radial neuropathies or median neuropathies, carpal tunnel syndrome, ulnar neuropathies, perineal neuropathies, they're all are neuropathies, but they're not the sort of thing that we would necessarily expect in Waldenstrom's. So that comes in the big category of neuropathies generally.
And now someone else asked, what blood tests are most important in monitoring peripheral neuropathy? I mean, so is there a way of trying to understand, perhaps going beyond blood tests, if someone develops peripheral nerve symptoms and, how do they know if it's going to get steadily worse or whether it might level off? Because people obviously begin to worry that they may become more and more disabled. Is there a way of telling whether something will be progressive or whether it will settle down a bit? I suppose that partly depends on what treatment people receive.
Yeah, so again, that's a big question, I suppose. So the answer to that is, in general, the anti-mag neuropathy that I've talked about is generally pretty benign. That is, it occurs and it causes problems in terms of imbalance and tremor and makes you not the person you were before. But I don't think I've seen anybody with an anti-mag neuropathy who's, for instance, needed a wheelchair. Some people need a stick because they're a bit unsteady, and some people have a particularly bad tremor, and that can be very disabling because it gets in the way. So in general, anti-mag neuropathy is a sort of benign condition in that it's there and is irritating and troublesome rather than disabling. There are some other neuropathies that can occur with Waldenstrom's that are more disabling and cause more trouble, and they are much rarer. And so therefore, it's important to identify those, and we could talk about those later if you wanted to. How do we monitor patients who've got anti-mag neuropathy? Well, interestingly, so some of that's done with the things that you measure in a way. I mean, we measure them together, but so you look at people's paraprotein, and if that is very stable and very low level, then usually it stays. And if it stays there, then the neuropathy doesn't get that much worse. In cases of patients whose paraprotein is going up and who we would be thinking about treating those patients for hematological reasons, then sometimes those patients do get worse. And if they are getting worse, then of course they need treatment. And treatment, usually, we have a few patients, don't we, where we've treated people and they've got dramatically better, particularly people who are the younger group in their 60s, 50s, perhaps they're unusual, who are progressing quite quickly, getting worse a bit quicker than we expect, who are within 5 years of the beginning of their symptoms. And some of those patients, when we treat them with the Waldenstrom's treatments, do get better. But mostly what we're aiming at is firstly identifying the people who don't need treating because they're going to stay fairly flat and don't therefore need to be exposed to drugs. And so we don't want to treat those, but also identifying the people who we do need to treat and treating them as soon as we can. And usually what happens is we manage to stop the decline and sort of make people flat and not get any more disabled. So then we monitor people with our clinical tests that we do. We've got a few scales that we use. We ask patients a scale called a RODS score, which is information about your how things affect you in terms of abilities. And I can measure some things in terms of power and sensation, which are semi-quantitative. They're sort of they do have a scale associated with them that I can measure on the couch. And sometimes we use the electrophysiology, the electrical tests to measure how things are changing. But at the moment, we're still rather blunt. And what we don't have, and in direct relation to your question, do we have a blood test that can say, oh, yes, you're going to get better, or you're going to get worse, or yes, you are getting better? We are working on that in the laboratory at the moment. And we do think we've got something that looks like a good marker of whether there's ongoing damage or less ongoing damage, which would help us to decide whether you need more treatment or no treatment or no more than you've had, if you see what I mean. So it's really difficult monitoring people, and that's some of what fills up our clinic is keeping an eye on people who we've treated, making sure they're not getting worse, or looking at whether they're getting better or not, and reassuring them.
Yes, indeed. And so, I mean, other than anti-MAG, there are a number of other mechanisms for nerve damage in Waldenström. So some are related to the paraprotein, which can act through other antibodies, not MAG. There's another group of antibodies that we do measure sometimes. They have certain slightly different features, but similar in some ways. But then there are some more alternative ways of inflaming and damaging nerves through, for example, inflammation of blood vessels that supply the nerves as they're not. I mean, someone has mentioned, it says, can feeling peculiarly cold at times be related to peripheral neuropathy? And that's one of the blood tests we do in patients, particularly with those symptoms, to look for something called the cryoglobulin. And that is something that is when the paraprotein has a peculiar feature that results in it getting all stuck together and gloopy in the bloodstream when temperatures are cooler. And, you know, many people do actually have cryoglobulins when you test them, but for those who are symptomatic, it could be relevant. And of course, one has to try and make the connection. But I certainly am always on the lookout for people who have thermostat issues, or who tend to get cold or intolerant when they didn't used to be. Because the thing is, if you do need to treat cryoglobulin, sorry, I was going to say, no, if they do develop, if you need to test for cryoglobulin, it's not a straightforward test. It's a bit of a faff. You have to get a sample. Not all laboratories do it. It's got to be kept in a flask. It's got to be delivered to the lab. But you know, I think there are times when we pursue this because the treatment can be perhaps slightly different.
Yeah, that's right. And as you say, cryoglobulins are difficult to sort of identify, and very frequently they don't do anything. They don't cause any neuropathy. Usually when we see a cryoglobulin related neuropathy, we get other features with it too. So it's because it goes gloopy in the cold, it usually affects the ends of things. It affects fingers and toes and the ends of your nose and your ears, often comes with a rash, sometimes that turns into an ulcer, particularly around the ankles. And so and usually it's a painful neuropathy as well, which differentiates that from an anti-MAG neuropathy, which is usually not painful. So they're fairly rare, but of course we do see those. And then, of course, there are other types of painful neuropathy that we see with a different mechanism, where the antibody can fall apart. So an antibody has what's called a light chain and a heavy chain. The heavy chain is the IgM bit, and the light chain is the bit that people may have heard of that's called kappa or lambda. And sometimes if those two dissociate from one another, they break up. So you get a light chain floating around. That stuff is a bit like, I liken it to scrambled egg on a pan. Those of you who've made scrambled egg in a pan that's not got PTFE on it, it's a nightmare to wash up, because the scrambled egg sticks to the pan, doesn't it? And when light chains dissociate from the heavy chains, they sometimes get stuck in nerves in a way that's a little bit like scrambled egg, and it's difficult to get rid of. And that can cause its own sort of painful neuropathy, although the features of that are it often affects people's sexual function. So people get erection difficulties, sometimes bladder and particularly bowel difficulties with diarrhea, and some weight loss, but it's a very typical type of pain as well. So again, that comes down to what you as patients tell us as to, oh, well, that's interesting, that's a different sort of neuropathy, and we need to do a different sort of test to pick that up.
And that's you're alluding to amyloidosis, aren't you? Which can also affect this enigmatic part of the nervous system called the autonomic nervous system,
which is where the bladder and bowel.
Yes, exactly. It's like the automatic nervous system almost. But so you can get dizziness when standing, your blood pressure can drop, etc. And so we sometimes send people to the National Amyloid Center for specialized testing if we suspect that amyloid may be playing a part. Now, in terms, you mentioned pain, Mike, actually, and it is a big feature for some people. And nerve pain is a bit different to other forms of pain, and I don't think responds as well to your average paracetamol or non-steroidal anti-inflammatories like Brufen. It's a sort of, I mean, you often prescribe certain classes of drugs, and there's a way of prescribing them, isn't there, so that you try and maximize benefit without getting too many of the toxic effects.
Yeah, that's right. In fact, so you're right. A background to most pain, actually, I think always should be paracetamol, unless of course there's an allergy to it. Paracetamol is an extremely good pain relieving drug in lots of ways. It works at brain level, and has almost at prescribed doses has almost no side effects. So it's a great drug that we should used in the background for lots of pain problems. But then, yes, you're right. So pain generated from nerves, when nerves are damaged, can be treated with a number of drugs that turn down that nervy type irritation. There are several classes of drugs that work there. So there are the, I saw a message ping up a little while ago about, is Lyrica the best treatment for neuropathy? So none of these drugs treat the neuropathy. I.e., when I think about treating neuropathy, I'm thinking about trying to make the neuropathy better, making the damage to the nerves better. And so these drugs are not treating the neuropathy, but they're making life easier. They're reducing pain. And so Lyrica, or pregabalin, and gabapentin, the trade name of which is Neurontin, are very commonly used to treat pain from nerves, particularly when it feels like the pain is coming from the ends of the nerve, this end of the nerves, the far end of the nerves. Now, pregabalin and gabapentin are now controlled drugs. That is, they come in the same class as heroin and cocaine, and they're but more controlled than marijuana is, which means that your GP has more difficulty prescribing them because they have a street value. I'm not entirely sure why they have a street value, I have to say, but everybody has their poisons and choices, but there we go. It just makes them more difficult to use. But they are very good at turning down pain. But of course, we're not clever enough yet with specifically picking out just sensory nerves to turn down those. And so...
You've gone on mute, Mike. Still.
Sorry, don't know why that went on mute, sorry. So gabapentin and pregabalin are very good at turning down pain, but in higher doses, sometimes people find them difficult to tolerate in terms of they make them a bit forgetful, or they have word finding difficulties. Gabapentin and pregabalin sometimes result in people putting on a bit of weight or getting a bit of ankle swelling. On the other hand, if they reduce your pain, a little bit of ankle swelling and no pain and being able to sleep is a sort of trade-off that you might be happy with. The other major class of drugs that we use for pain are what are termed and licensed as the tricyclic antidepressant drugs. So I really don't like the way that we name drugs in this country. I think the tricyclic antidepressants, in fact all antidepressants, should be called neurotransmitter modulators, because that's what they do. They change neurotransmitters in your brain, and you can use them for all sorts of things. And I use tricyclic antidepressants for treating migraine. I use them for treating depression, of course, anxiety, and actually what they're really good at is treating pain that comes from up here at this end of the nerves, the nerve roots. And you use them in small doses. They often help sleep, particularly in people whose sleep is disturbed by pain or burning, and can be really, really good. And people who have loose stools in amyloid, for instance, it slows down bowel function as well, so you can help their diarrhea. And so quite often, actually, I'm prescribing pain medications not on the basis of, I mean, I know they'll all turn down pain one way or another, but I'm using them for their secondary effects. So somebody who has no sleep, I'm quite happy to use amitriptyline to help you sleep, because if you have better sleep, you'll have better pain control. Or if one's very depressed or anxious, then again, you might get a secondary effect of improving mood as well as reducing pain. But on the other hand, if you pregabalin or Lyrica is very good at turning down anxiety, and if the pain is from out here, then I might choose pregabalin or Lyrica. So it's often a matter of choosing the best drug for the job and using some of the side effects to to your advantage, to my advantage. So there are various choices. And of course, some people have very bad pain, and in that situation, we might use opioids. There are some very nice opiate drugs that come in patches that you can stick on the skin. They last for 3 days, therefore you don't have to keep taking medication. You get a nice steady level of control, but they're usually used later on. And then there are some drugs that are used in pain clinics that are in infusions. So there are quite a lot of options for pain, but I wouldn't claim to be a pain doctor and an expert in treating pain, because I'm not very good.
But I think, I mean, we'd agree that we've seen a lot of patients for whom pain does really affect their quality of life. And I think I know a lot of patients with Waldenström's do end up on lots of medication. So it seems almost perverse to say, oh, have another medicine if you've got pain. But, you know, to be honest, I think that if you have pain that is due to a neuropathy, obviously we try and address the underlying cause of the neuropathy. But if that pain is persisting and is going to be with you, I think it is worth giving these pain meds a try, because it could improve the quality of your life. And bear in mind, it's not a one-way ticket. You can try. If it doesn't work, you can, you know, have an adjustment. And I think one of the difficulties is that doctors have different levels of experience in how they prescribe these drugs. And I mean, I've learned a lot by working with Mike, because I see how he prescribes them. It's building up certain drugs to a certain level, giving it a few days at a time before you sort of decide that's enough or not enough, and sticking with it, really. So you sometimes almost have to put time aside to allow yourself to adjust. But it actually can make a big difference to an individual and the way they feel. And the more pain you have, it's more tiring. The more tired you have, you lower your pain threshold. You know, it can be a really vicious cycle. So I think that is something that is worth persisting with if that is a feature of your neuropathy.
And I think that's right. And all drugs that work have side effects. There is no question about that. Drugs that don't work don't have side effects, and so drugs don't get to market unless they've got an acceptable lowish level of side effects. And some of these drugs that we are using, and the gabapentin and pregabalin, they were designed as anti-epileptic drugs to start with, but work well for pain. So they're designed to turn down our brains in a way. And antidepressants, the old ones that we use for pain, are rather broad in their action, and so therefore they will have broader side effects, which yes, we can use to our advantage, but it does usually mean quite often the side effects come early and then go away, and the therapeutic effect, that is the treatment effect, comes later once the side effects have settled down. So I like to start low and carefully and slowly and build up gently. If it doesn't work, then we can stop, and they don't have any long-lasting effects, so that you can to drop off them again, and they don't leave a mark, as it were, in nearly every case. Of course, there will always be cases where there's a sort of, this is something funny, but I genuinely don't believe they leave a mark. And if they don't work, then they don't work. And if they're not tolerated, they're not tolerated. But usually you can find a point where at least they'll give 30 or 50% relief from pain.
And the other thing is that just because you happen to be suppressing the pain, it doesn't mean you're damaging the nerves in any way. The nerve damage has a life of its own. So covering the symptoms or improving the symptoms is a separate matter.
Yeah, and often people will come to see me in the clinic and say, I didn't take my pain medications today and yesterday, so you could see my neuropathy, which I always think is, well, I don't think people should put themselves through that. Very considerate of them, but I can see the neuropathy despite the pain medications. So they don't affect the neuropathy in terms of fixing it or squashing it. So it's still there. It's just the way that the pain hopefully doesn't manifest as strongly.
So yeah, so I mean, so there's a whole cluster of conditions related or associated with Waldenström's, with IgM paraproteins. We obviously try and drill down on what the cause is. Is there a connection? And then, of course, we do think about how to treat that. And there are, I mean, so if we establish that the neuropathy is driven by the underlying Waldenström's, then we need to treat the underlying cause, which is the Waldenström's or the IgM. It may not be Waldenström's. It may be more like an MGUS, a low level of cells which don't need treatment in their own right. So we do that by using treatments that are used to treat Waldenström's. And of course, we try and select, depending on the problem that we have to deal with. So if it's neuropathy in the presence of active Waldenstrom's disease that itself needs treatment, then of course using chemotherapy combinations like DRC or BR or whatever is a good approach. If, on the other hand, the Waldenstrom's is not so active and busy, but it's causing nerve problems, then we tend to be a little bit lighter with the treatment. But this is very much work in progress. And because it's a rare sort of phenomenon, it's very difficult to do trials and figure out exactly who needs what. And I think I think we have built up a body of experience in looking after patients. So we tend to do a bone marrow if we're going to try and treat someone with an underlying Waldenstrom's related neuropathy, even if they've obviously had one previously. Before treating, we tend to sort of gauge what is the level of Waldenstrom's, what is the scale of the problem. Should we use some chemo with the rituximab, which is a very effective drug in these cases and widely used. So we try and match like for like, and newer drugs like ibrutinib, zanubrutinib, they have, they also, for the same reason, targeting the underlying disease, they can help to ameliorate the problem over time. But there are some subtleties in certain areas. So, for example, amyloid related to IgM doesn't respond so well to ibrutinib, which is a shame, perhaps due to the speed of response. So at the end of the day, we have to make a case-by-case decision on how to treat patients with Waldenstrom's and neuropathy. Someone has asked, Mike, is CIDP related to WM?
Okay, that's a good question. Not directly, no, but CIDP, chronic inflammatory demyelinating polyradiculoneuropathy, which is why we call it CIDP, is a demyelinating disease. That is, sorry, the dog has now jumped on me completely, so apologies if she makes an appearance. It is a demyelinating disease. That means the insulating sheath of the nerves is damaged, a bit like it is in anti-MAG neuropathy. And so it would be what we'd call one of the differential diagnoses. If you had demyelinating neuropathy and anti-MAG antibodies, and you had that typical electrical picture, then I would call it Waldenstrom's or anti-MAG related neuropathy. But if you didn't have any of those linking features, then some patients have CIDP. And going back to what Shirley was saying about treatment, so Waldenstrom's neuropathy doesn't respond to IVIG, intravenous immunoglobulin, which is an infusion of antibodies, which is extremely expensive. It's about £5,000 a dose.
Scarce.
And scarce, yeah. So Waldenstrom's neuropathy doesn't respond to that, whereas CIDP does. So even if you had Waldenstrom's and an IgM paraprotein, and we gave you some IVIG and it worked, I would still call it CIDP rather than Waldenstrom's neuropathy. The other question that I saw somebody pinged up there as well, which was interesting, was why do some people respond to rituximab and some people don't, and do we know why? There's two answers to that there, yes and no. Do we know why? There's always the question about, is the neuropathy caused by the Waldenstrom's? And if it's a neuropathy that's not caused by Waldenstrom's, then it won't respond to rituximab. So that is always a question that we have in our mind. Then the antibodies, the anti-MAG antibodies, are all produced by B cells. They're a type of white cell. And B cells I imagine B cells a little bit like a child growing up. Or that you've seen those pictures where going through from childhood to adulthood and then to being older, and then so I imagine B cells a bit like that in their lineage. And rituximab is what's called an anti-CD20 antibody, and basically it removes all the B cells from sort of late teenagehood to late adulthood. But there are things at the far end of the B cell pathway called plasma cells. They're your memory, your immune memory. And anti-MAG antibodies can be produced from plasma cells. And plasma cells don't have CD20 markers on them, and so rituximab doesn't remove those. And so if you've got anti-MAG antibodies being produced by those plasma cells, which we can't unfortunately test, then you won't respond to rituximab, but you would respond to the other chemotherapies perhaps that Shirley talks about, DRC, which is steroids and cyclophosphamide. But that's a triple chemotherapy regimen, which it has a few more side effects and risks to it. And so we have to try and judge the right treatment for the right person. Do you need treatment? Should we use just single agent rituximab because we think we'll get a good response? Should we be using something more complex like DRC, or should we be using something like ibrutinib at some stage? So they're all sort of questions about what we should be using. And sometimes we use single agent rituximab and then people don't respond, and then we go on to using DRC. So it really is an individualized choice from patient to patient to help make you as best as we can. I will say at the end of it that although we understand a lot about the nerves, which I guess where I started from 25 years ago, we understand an awful lot about how these nerves are damaged. What we don't understand in neurology generally is how to make nerves regenerate successfully in any disease. And I would probably be extremely rich and not sitting here if I knew the way to make people's nerves get better and fix them and make them join up again in the right. But we don't have those treatments yet. And we're making inroads into once you've stopped the war, excuse me, stopped the damage, the next thing that we need to do as neurologists and scientists is learn how to make nerves better and regrow, and that might come in the next years or decades, and then I think people's lives will be much better once we can reprogram nerves to grow back.
Now, another really important question is of last one, perhaps, Bob.
So can I just answer DRC? Sorry, I used a phrase that I should use. DRC stands for dexamethasone, that's cyclophosphamide. Dexamethasone is a steroid, rituximab, which is rituximab, and C is the cyclophosphamide. Sorry, I sometimes bandy terms around that I shouldn't. So there's
a very important question here about physiotherapy and occupational therapy, and perhaps we should also mention orthotic support, because they actually can make a massive difference to patients.
Yeah, so hugely, and I utilize my physiotherapists and occupational therapists a lot, again, on an individualized basis. Quite often, actually, when we don't treat people, somebody who's got some mild unsteadiness and sensory loss in their feet, I often think that I would do better asking my physio OT team to really evaluate their footwear and their orthotics in the shoes and make sure their feet are in the right place, and have a really good pair of supportive trainers and a good stick that's the right length, and that saves a lot of unnecessary chemotherapy. But people who are weak can really, in their ankles, who get imbalanced because they're weak, some of the orthotics we use can really help, as can a stick. I'm very keen on promoting elegant sticks that people can use to just have a third point of contact with the ground, which really helps them balance a lot. And physiotherapy can help in terms of helping with balance and reducing falls and advising on walking aids. But in a way, there's no magic about physiotherapy. They help you use the bits that you've got that you didn't realize that you had, and can, again, help make life easier where we can't fix things completely.
I've got a question for you, Mike. It's under threat of death if I don't ask you, and it is: do you feel that anti-mag is responsible for tremor and jerking? One of my fellow patients has a problem with that.
Yeah. So again, a big question. So jerking. So when people describe jerks, that for me is a different thing that doesn't. So jerking is quite normal in our lives. We've all had that experience, I'm sure, of that feeling like you're falling out of an aeroplane when you're going to sleep, and you sort of go boom, and that's a big jerk. That's what's called a hypnagogic myoclonic jerk. So that's normal, and you can get those going to sleep and waking up. And some people get them when they're just sitting at rest. They get the odd jerk here and there of a limb or a shoulder or something. So, and they're myoclonic jerks, and they're relatively normal. They also occur in an awful lot of other neurological diseases, and so they're not terribly differentiating. But most jerks are normal. Tremor and that typical tremor that I showed you, that it's got those sideward movements and the sort of slightly irregular flappy look to it, it is caused by the neuropathy in many cases, and that is related to the slow conduction because of the damaged insulating sheath. And so sometimes when we treat patients, their tremor can get better. We have seen a number of patients who we've treated and their tremor has briefly got much worse for a month or two before it gets better. And that's a function of trying to make nerves better. So yes, tremor is caused in some cases by anti-MAG antibodies, not always, but quite often. Jerks are usually not, although the tremor is a bit jerky, and jerks might be normal or caused by another condition. And if you've got bad jerks, there are other drugs that we might use to treat them.
The person, yeah, I was going to say the person that asked me to ask you that question has to eat with a spoon because they're dangerous with a knife and fork. Their jerks are that bad. Yeah.
So sometimes, I think when I didn't realize who I was writing back to or why when I wrote those answers back to you before, Bob. So I think it's worth that person seeing a neurologist to identify whether they're jerks or tremor. So jerks that do that sort of thing where you've got a spoon and suddenly the contents of the spoon or the fork sort of ping off somewhere, those jerks can be settled down with other drugs like clonazepam or piracetam or levetiracetam. There are lots of drugs that can help that. Sometimes when it's just a very bad jerky tremor that throws things off a spoon, sometimes we use botulinum toxin in an arm to semi-paralyze it a bit, not completely paralyze it, just turn off the bad tremor. And sometimes if it's a more atypical tremor, we can use some other drugs to sort that out. So very worthwhile being evaluated by a neurologist for those tremors and how they affect things, so that you can get the right drug to turn it down. But again, it's always a problem of turning the tremor or the jerks down without turning the person down.
Thank you. Shirley, that's an hour. One last question that's come in there. Can I ask that? Is how to tell the difference between sciatic pain and peripheral neuropathy pain?
So sciatic pain is I mean, sciatica, so that's sciatic pain, usually radiates from a back with a back pain. Frequently there's a horrible ache in a buttock, and usually the pain radiates down to land in a specific point at the bottom of a leg, in the top of the foot or the bottom of the foot or the back of the calf. And it would be lateralized. Of course, you can get bilateral sciatica. Peripheral neuropathy pain is usually of different quality. It's often got some tingles, sometimes some numbness within it. It's usually symmetrical, and usually starts in the toes and sort of works up. So there is a difference between those two. I have to say sciatica is probably far more common than peripheral neuropathic pain.
Thank you.
There's a few questions about a treatment. I mean, in general, obviously that is a kind of a big topic because there are many new treatments. The broad answer is that there are new treatments coming online which are very likely to help neuropathy problems as they treat the underlying Waldenstroms. We have no evidence that BTK inhibitors such as ibrutinib actually make neuropathy worse. Correct me if I'm wrong, Mike.
That's right.
I think it's more a question of whether if you have a neuropathy and you're having treatment, whether the response to the treatment is keeping up with the nerve recovery and so on. So one has to be quite flexible in the time scale and the assessment and before we say a treatment has helped or not helped. And I think one other thing that people may say is, look, you've got this joint clinic, but it's often difficult to actually get access to neurology and to nerve conduction tests and so on. And I do recognize this because we get a lot of patients referred in actually by other neurologists or other hematologists who are experts in their own right in how they manage their patients. But this is a bit of a niche field. And so, you know, please feel able to kind of be a little bit kind of pushy if you're really struggling, because we are very keen to spread the word about how to manage WM in its, in a very broad scope of things. And, I think we're pleased to be able to spread the word through conferences, through webinars, to try and, because not everyone can do everything and look after every patient. But please be vocal in seeking help and advice, and obviously come through WMUK as well.
And quite often we can do, obviously we're where we are, and people are all around the country, and sometimes difficult to come. But quite often we will answer queries from other consultant colleagues by email, because it's easy to do that. They say, I've got some jerks and might send us a video, for instance, and I'll look at that and say, okay, we can treat that with this drug or that drug. So and it saves a long journey from I don't know, wherever, Wales or Cornwall or whatever, and something that I can do on an email and a video. It's very difficult to do a full consultation by video. Obviously during COVID we did lots of remote consultations, but actually I will tell you, I only did 2 video consultations during the whole of COVID, because both patients fell off their chair trying to show me something in their leg, and I decided that after that it was probably too dangerous to see people on the video. So I did a lot of telephone calls, but it's much easier to see you face to face if we need to, and we're happy to say, look, I can't do this on an email or a video, please get referred up, and then I can see you and sort of get arms and legs in my hands. These I always regard as better tools than an MRI scanner. That sounds rather arrogant, but they work quite well.
No. I have a word for it. It's called a Lunnogram.
Hey guys, I'm gonna bring this to a close now. We've been going for just over an hour. And by the way, Mike, I happen to know I do a bit of work with prisoners in ex-military prisoners, and gabapentin is the drug of choice in prisons at the moment. Right. Did you know that? Yeah.
No, it's got. I mean, I know. It's
remember
got a huge
when we go to
stream,
prison?
Yeah, exactly.
They call them gabbies. Yeah.
Gabbies. Yeah, I have no idea what they actually do. Anyway, there we go.
No, I don't. So I think on behalf of everybody here tonight, we had 68 of us here at one point from all over the country. Lots of faces that I know, some that I don't know. I think on behalf of everybody, I just want to say a big thank you to you both for giving up your Monday evening for us. It's been a really, really interesting webinar. Mike, you've opened the window on neuropathy. I know you haven't come up with a cure, which is what we were all hoping for, but never mind. Years. Maybe in the future.
Yeah, I've got a few years left.
Yeah. So keep researching, and thank you both so much. We really appreciate it.